Hello everyone, I am myself Dr. Rajesh Gubba. In this particular session, I'll be discussing a very important topic in the cardiology, and that is also a very common clinical scenario which we come across in our clinical practice, that is the acute rheumatic fever. So if you see the acute rheumatic fever, first and foremost, you need to understand the basic epidemiology. That is, it is very common in children of age group 5 to 14 years of age. Okay. Whereas you take in young adults and as well as in individuals of more than 30 years, this is rare or less common in this particular age group. Okay, so rather than using the word rare, it is better to use the word less common. Whereas you take the recurrent episodes of the rheumatic fever, they are the one which are very common in young adults, and they are also common in the adolescent age group, right? Whereas if you take the incidence of rheumatic heart disease, right, where there is the cardiac involvement, this incidence of rheumatic heart disease, it peaks, right? The peak age is between 25 and 40 years of age, right? Between 25 and 40 years of age, the incidence of or the prevalence of rheumatic heart disease, it peaks. And if you take the gender difference between females and males, it is more common in females rather than males. And how common? It is almost twice in females rather than males. Now, if you see the pathogenesis of the development of rheumatic fever and rheumatic heart disease, first you need to know what are the organism factors, what are the host factors that will be responsible for the development of this acute rheumatic fever. So if you take the organism factors, what is the organism? First of all, the organism, it is acute rheumatic fever. It is an recurrent inflammatory response which occurs in response to group A beta hemolytic, right? It is group A beta hemolytic streptococcal infection of skin and throat. Okay, group A beta hemolytic streptococcal infection of skin and as well as throat. Now, what you have to remember is that it is not a direct infection of group A beta hemolytic streptococcus to your joints, directly to the heart, directly to the skin, directly to the brain. No, it is not the direct infection of this organism to this multiple organs. It is a recurrent inflammatory immune mediated response against these multiple organs of the host is what is your rheumatic heart disease. Now, which particular serotypes of group A beta hemolytic streptococcus are responsible for this acute rheumatic fever is, it is serotype 1, 3, 5, 6, then followed by that we have 14, then 18, 19, 24 and then 27. These are the M serotypes which are responsible for the development of the acute rheumatic fever or rheumatic heart disease, and even serotype 29 as well. So these are the serotypes which are responsible for the development of your rheumatic fever, and these serotypes actually they cause the throat infection or the skin infection. Now the skin infection which is being caused, what exactly it is called? It is called impetigo, right? This is called impetigo. Now let me discuss what are the host factors. So if you take the host factors, what has been found is the incidence of any population, you take any group of population, the incidence of this rheumatic fever, it is nearly seen in around 3 to 6% of the general population. And what has been found is the familial clustering of the cases. That means there is chance of inheritance. That is, inheritance in the sense like mother or the father had the history of rheumatic heart disease or acute rheumatic fever, the chances that in children they are increased or they are more prone for acute rheumatic fever, that particular sort of familial clustering is there. And what percentage is that? It is more common in monozygotic twins. So if you take in monozygotic twins, right, in monozygotic twins, the familial clustering or inheritance is nearly around 44%. Whereas you take the dizygotic twins, the chance of developing acute rheumatic fever in among dizygotic twins is around 12%. Now, there are certain HLA factors which are at increased risk of development of rheumatic fever, and some of the HLAs, they are like protective in nature. Now, what are the HLAs which have increased risk of development of acute rheumatic fever? That includes HLA DR4 and as well as DR7. These patients with this following HLA, they are at increased risk of development of rheumatic fever. Whereas certain HLAs, like they are protective. What are those? Like HLA DR5, then DR6, DR51, DR52 and HLA DQ. So these HLAs, they are protective in development of the rheumatic heart disease, whereas presence of HLA DR4 and DR7, they are at increased risk of development of rheumatic heart disease. Then apart from this, certain polymorphisms are also polymorphisms in the host, they are also at increased risk of development of acute rheumatic fever. That is, number one, polymorphisms of tumor necrosis factor alpha 308, they are at increased risk of development of acute rheumatic fever. Next, the presence of high levels of circulating mannose binding lectin. MBL stands for polymorphisms of mannose binding lectin and polymorphisms of toll-like receptors. Okay, so these are the host factors. Familial clustering, very common in case of monozygotic twins, then dizygotic. HLA DR4 and DR7 presence, they are at increased risk of rheumatic fever. Presence of DR5, DR6, 51, 52 and as well as HLA DQ, presence of these HLA, they are protective against the rheumatic fever. Then polymorphisms of TNF alpha 308, mannose binding lectin and as well as the polymorphisms of toll-like receptors, they are at increased risk of development of rheumatic fever. Now, you need to know what exactly happens within the host. So, what exactly that happens in the host? That is the immune response. What is that immune response? You need to understand about what is called as the molecular mimicry. What is this molecular mimicry? Molecular mimicry is that the immune system of the host, it gets activated, right? Immune system of the host, it gets activated. This immune system, it will produce the antibodies, and these antibodies, they are targeted against M protein and they are targeted against N-acetylglucosamine. Okay, right? The immune system gets activated, they produce the antibodies against the M protein and as well as N-acetylglucosamine of group A beta hemolytic streptococci. Now, this particular antibodies which are being produced against M protein and as well as N-acetylglucosamine, it has the molecular mimicry. That means your M protein and as well as N-acetylglucosamine of your group A beta hemolytic streptococci, they appear molecularly similar to that of the heart valves. It has the similarity with the joints, it has the similarity with the skin, it has the similarity with the brain cells. So, the antibodies which are formed against this M protein and as well as N-acetylglucosamine, they attack these heart valves because the structure of the heart valves is similar to that of the M protein and as well as the N-acetylglucosamine. So these antibodies, right, they bind to the endothelial cells of the heart valves. Once they bind to the endothelial cells of the heart valves, there is activation of the adhesion molecule. What is that adhesion molecule that gets activated? That is VCAM1 that gets activated. And once your VCAM1 is activated, there is recruitment of the activated lymphocytes. Right? Recruitment of the activated lymphocytes. Okay. So once there is recruitment of the activated lymphocytes, these lymphocytes which have been recruited, they cause the lysis of the endothelial cells. Right? They cause the lysis of the endothelial cells on the heart valves. And not only that, this endothelial cells, once they have undergone lysis, they will release the peptides. Right? The degenerated or broken endothelial cells, they will release the peptides. Now, what are these peptides? These peptides, they include laminin, keratin, and tropomyosin. Okay. So there will be release of these following peptides. Now, the peptides which are being released from broken endothelial cells, what they try to do is they activate and they cross react with the T cells. So basically they activate the T cells, right? And once these T cells are being activated T cells, they invade the heart, right? They invade the heart and they amplify the damage. They increase the damage. Okay. So this will be the sequence of events that will happen. So very important is molecular mimicry. That is the antibodies which are being formed against the M protein and as well as inositol glucosamine structure of group A beta hemolytic streptococci. They cross react with the endothelial cells of the heart valves. So once they bind to the endothelial cells of the heart valves, there is activation of the adhesion molecule, that is VCAM1, and activated adhesion molecule VCAM1, it causes recruitment of the lymphocytes, and these lymphocytes, they cause the damage of the endothelial cells by the complement, and this degenerated or damaged endothelial cells will release the peptides, that is laminin, keratin, and as well as tropomyosin. And these released peptides, they activate the T cells, and activated T cells, they invade into the heart and they amplify the damage of the heart. So this is what is your immune response based on the molecular mimicry. Now, apart from this molecular mimicry, there is one more alternative hypothesis. The alternative hypothesis is that the initial damage is due to, right? What is this alternative hypothesis? This tells that the initial damage is due to invasion of streptococcus into endothelial cells of the valves. Right? The initial damage is due to invasion of the streptococcus into the endothelial cells or onto the epithelial surface. Now, this invaded streptococcus, what it does, it binds to the M protein of the type 4 collagen. This particular streptococcus, it binds to the M protein, right? It binds to M protein of the type 4 collagen. And once it binds to the M protein of the type 4 collagen, this becomes immunogenic. Now, what do you mean by the word this becomes immunogenic? That means when it is binding to the M protein of type 4 collagen, the streptococcus which is being bound becomes immunogenic, and thereby the immune system gets activated, and the activated immune system will not only destroy the streptococcus, will also try to destroy the type 4 collagen as well. So this is an alternative mechanism to that of the molecular mimicry. Okay, so this is about the immune response. One is molecular mimicry, and the alternative hypothesis is directly streptococcus invading onto the epithelial surface and thereby binding of M protein to the type 4 collagen. That means the M protein of the streptococcus will bind to the type 4 collagen, and once the immune system is activated, they destroy this M protein along with the type 4 collagen. Okay, so this is about your immune response. Now, after having discussed about the immune response, you need to know about the clinical features. If you take the clinical features, immediately after the onset of the infection, the clinical features of the rheumatic fever does not develop. The latent period is nearly around 1 to 5 weeks. On an average, it is around 3 weeks. Right? And on average, it is 3 weeks. Okay? Right? That means after 1 to 5 weeks of entering of group A beta hemolytic streptococcal infection, there will be appearance of the clinical features. But the exceptions is for the clinical features like chorea. Chorea, it has a prolonged latent period. And how much will be that prolonged latent period for the chorea? That is nearly around 6 months. And majority of these patients with the acute rheumatic fever, they give the past history of the sore throat, right? And this particular sore throat, it might have been caused by group A beta hemolytic streptococcal infection. Okay, right? So there is the majority of the individuals, they give the past history of sore throat infection. Now, what will be the most common clinical feature in patients with acute rheumatic fever? Remember, it is your polyarthritis, and that too the involvement of the large joints. After the polyarthritis, then it is followed by that it is carditis. So if you take the percentages also, polyarthritis, it is seen in nearly around 60 to 75% of individual, but carditis, it is seen around 50% of individuals to maximum of 75%. So polyarthritis is the most common manifestation, then followed by that the carditis. Okay, so first let us discuss the cardiac involvement, and then subsequently the joint, skin, and as well as the brain involvement, because the antibodies which are being formed against the M protein or against your N-acetyl glucosamine, these antibodies, they cross react with the joints, they cross react with the heart, they cross react with the skin, they cross react with the brain. So in that way you have the multi-system infection. Now cardiac involvement, what did I discuss just now? It is around seen in around 50 to 75% of patients. Okay, 50 to 75% of patients, they progress to the development of the rheumatic heart disease, and it is pancarditis, all the three layers, that is endo, myo, and as well as pericarditis. Right, so there is endocarditis, myocarditis, and as well as pericarditis. All the three layers are being affected. And what is the hallmark of the rheumatic carditis? The hallmark of rheumatic carditis is the involvement of the endocardium, that is in the form of the valvular damage. And what is the most common valve that is being affected is the mitral valve. And this mitral valve involvement, occasionally it will be there along with the aortic valve involvement. But isolated aortic valve involvement, right? Isolated aortic valve involvement, it is rare. Okay. And what about the tricuspid valve and as well as the pulmonary valve involvement? So the tricuspid valve and as well as pulmonary valve involvement, it is usually secondary to, right? So this is secondary to increase in the pulmonary artery pressure, right? And this increase in the pulmonary artery pressure, it results from left-sided valvular pathology. Okay. So secondary to left-sided valvular pathology, there will be increase in pulmonary artery pressure. Secondary to that, there will be involvement of your tricuspid valve and as well as the pulmonary valve. So that is about the basic introduction of the cardiac involvement. Now, if you take this valvular involvement, this is what is your hallmark we have discussed. Now, in acute rheumatic fever, what will be the cardiac involvement, and chronic, what will be the cardiac involvement? So in early stages, the most common valvular heart disease in acute rheumatic fever, right? Most common valvular heart disease in acute rheumatic fever, that will be the mitral regurgitation, right? Early valvular damage, it leads to the mitral regurgitation. Okay. And the next important is there can be progression to the development of the aortic regurgitation as well. But whereas in case of chronic rheumatic heart disease, right, whenever there is recurrent episodes of the rheumatic heart disease, what can happen to the valves? You know, these particular valves, they get ulcerated, right? They get ulcerated, they get scarred, right? And there will be, right, there will be thickening, there will be calcification, and all these will make the valve into a state of the stenosis. So that is the reason why if the question is asked what is the most common valvular involvement in chronic rheumatic heart disease, that will be mitral stenosis, whereas in acute it is mitral regurgitation. Now, apart from this valvular involvement, you know, in these patients with rheumatic heart disease, there will be also prolonged PR interval. Now, what would be the cause for the prolonged PR interval? So, there will be myocardial inflammation, and this myocardial inflammation, it can progress to the internodal fibers. So, internodal fibers are those which will connect the SA node to the AV node. So, this myocardial inflammation, once it affects the internodal fibers, then there will be delay in the conduction, right? There will be delay in the conduction of the electrical impulses from SA node to the AV node, and that will cause the prolongation of the PR interval. Okay, so there will be prolonged PR interval, and secondary to this prolonged PR interval, if you auscultate the heart sounds, so how will be your first heart sound? The first heart sound, it will be soft. Okay, first heart sound, it will be soft. So this is about your prolonged PR interval. And why is that? That is due to myocardial inflammation. Next, the other points what you have to remember is people with rheumatic heart disease, they often remain asymptomatic for many years, right? They remain asymptomatic for many years before their valvular disease, right? Before their valvular disease progressing to the heart failure, right? Progressing to the heart failure. They remain asymptomatic for many years. Then the next point is the echocardiography. So because they are asymptomatic, right, how can you identify that the individual is having an underlying rheumatic heart disease? That is by doing echocardiography. So echocardiography will diagnose the underlying valvular heart disease, and echocardiography should be done mainly as a screening tool. It should be done in those individuals who are like high risk age group, like for example you take school aged children, or if that particular area is under high risk of development of this rheumatic heart disease, in them you need to do the screening of the heart by doing echocardiography, wherein you will pick up the presence of the rheumatic heart disease if the individual is asymptomatic. Now this echocardiography, there is a criteria, right? Based on echocardiography you are diagnosing that there is rheumatic heart disease. Now what is the criteria? World Health Federation criteria, this echocardiographic diagnostic criteria for rheumatic heart disease of age group less than 20 years. So how is this criteria being classified this into a individual with definite rheumatic heart disease even though asymptomatic, borderline rheumatic heart disease even though asymptomatic, individual with normal echo. Now before going on to the telling it as definite, borderline and normal, you should know what is the criteria to call pathological MR on the echo, what is the criteria to call pathological AR on the echo, then what will be the morphological features of the mitral valve in case of rheumatic heart disease, then what will be the morphological features of the aortic valve in rheumatic heart disease. So all that we will discuss first, then we will discuss what is your definite rheumatic heart disease, what is borderline, what is normal echo. Okay, now first you take the pathological MR. So now to define pathological MR, either you should define it in two views, right? That is your apical 4-chamber view and as well as parasternal long axis view. Okay, that is Plaque's wave and as well as apical 4-chamber view. Or if not in 2 views, in at least 1 view, there should be presence of the MR jet. And how much should be the jet length? Jet length, if you see, it should be around 2 centimeters. And what should be the peak velocity of this jet length? That should be more than 3 meters per second. And there should be the jet which should be there throughout the systole. That is, there should be a pansystolic jet in one of the envelope. So this is about your pathological MR. Then what about the pathological AR? So how much should be that regurgitant jet? So this regurgitant jet of AR, you should see either in 2 views or in at least in 1 view. Okay. Now, how much should be that particular jet length? Jet length in AR, it should be more than or equal to 1 centimeter. Whereas if you take the jet velocity, the peak velocity, it should be more than or equal to 3 meters per second. And the jet what you see is in the diastole. So you will have a pan diastolic jet. Okay, so presence of these 3 tells you that the individual is having pathological AR. And if you see the morphological features of the mitral valve to consider it as the rheumatic heart disease. So first and foremost, the thickness. If you observe the thickness of the mitral valve, it should be more than or equal to 3 mm. Right? It should be more than or equal to 3 mm. And how should be the chordae tendineae? Right? There should be caudal thickening. That is another important criteria to tell. It is a pathological mitral valve. And leaflet mobility. Right? Leaflet mobility, it should be reduced or restricted. And the other point is the leaflet tip. There should be excessive leaflet tip motion. Okay. So this is about the morphological features of the mitral valve in rheumatic heart disease. Thickness should be more than or equal to 3 mm. Chordae should be thick. Leaflet mobility should be reduced and increased leaflet tip motion. Then morphological features of the aortic valve to consider it as the rheumatic heart disease. So how should be the aortic valve? The aortic valve, it should be irregular, right? It should be irregular, or there should be focal thickening of the aortic valve, right? Irregular or focal thickening of the aortic valve. And there should be coaptation defect, right? Coaptation defect within the aortic valve. That means the aortic valve should not be able to close completely, and then only there will be development of AR. Or there should be prolapse of the aortic valve into the left ventricle. So these are the morphological features of the aortic valve to consider it as the rheumatic heart disease. Okay. Now, so these are the pathological features of rheumatic heart disease in MR, AR, aortic valve and mitral valve. Now, let us define when do you call definite, when do you call borderline, when do you call normal echo. So, you take the definite rheumatic heart disease, right? When will you call definite rheumatic heart disease is there should be pathological MR, right? At least 2 morphological features of rheumatic heart disease of the mitral valve should be present. What should be the 2, right? Either of these 4, at least 2 should be there to call it as the pathological MR. Or you take these 3, jet length, velocity, pansystolic jet. Out of these 3, at least 2 should be there to call it as pathological MR. Then next is the gradient. If suppose if it is mitral stenosis, the gradient across the LA and as well as LV, it should be more than or equal to 4 millimeters of mercury. Then when will you call pathological AR? Pathological AR and at least 2 morphological features of rheumatic heart disease should be there. What is that? You see, we have totally 3 features of pathological AR. Out of these 3 features, at least 2 should be there to call it as definite rheumatic heart disease. So 2 out of 3. Next, borderline disease of both mitral valve and as well as the aortic valve. That means, see, the aortic valve morphological features and aortic valve, mitral valve and aortic valve morphological features should be like borderline. Then we call it as definite rheumatic heart disease. So all these where we are describing in an individual of less than 20 years who is asymptomatic, how to make out whether the individual is having rheumatic heart disease or not. Definite rheumatic heart disease is that pathological MR, at least 2 features should be there. MS gradient more than or equal to 4 millimeters should be there. Pathological AR 2 out of 3 should be there, and borderline mitral valve and as well as the aortic valve feature should be there. Then next is borderline rheumatic heart disease. When will you call borderline? Previously what we were discussing was definite. See, 2 morphological features of rheumatic heart disease of the mitral valve without pathological MR, right? No MR, no MS. Now, what do you mean by the word 2 morphological features of rheumatic heart disease of mitral valve? See, regarding the mitral valve, we have discussed these 4 should be there in rheumatic heart disease. Out of these 4, at least 2 should be there, right? At least 2 should be there. And the point is, these individuals, they should not have MR or MS to call it as borderline. And pathological MR apart from the valve, right? Pathological MR apart from the valve abnormality, that should be there. Pathological AR apart from the valve abnormality. So when will you call borderline rheumatic heart disease is either the individual should be having A, this is your A, or the individual should be having B, right? This is your B, or the individual should be having C. This is your presence of pathological AR is C, right? The same story applies even for definite rheumatic heart disease also. Even for definite rheumatic heart disease, this is your A, B, C, D. All these need not be there to call it as definite rheumatic heart disease, right? Either A or B or C or D. Similarly, if it is A, only mitral valve abnormality should be there. MR and MS should not be there. If it is MR, only MR should be there. But mitral valve abnormality should not be there again. That is, thickness and all should not be there. Only jet length should be increased. And if it is AR, only AR should be there. Okay. So this is what is called as borderline rheumatic heart disease, right? Then next is you should know when to call normal echocardiographic picture. Okay. Right. Here MR will be there, but does not meet the 4 Doppler criteria. We were just discussing for MR 4 criteria. MR will be there, but 4 criteria of that MR are not there. Okay. What will be that 4 criteria? You see, I'm sorry, 3 criteria. Jet length 2 centimeters, velocity more than or equal to 3 meters per second, pansystolic jet. That will not be there. Okay. This is for normal echocardiography. AR will be there, but does not meet the criteria of AR. And morphology of the mitral valve, if you observe, there will be valvular thickening, but does not meet the criteria of the rheumatic heart disease. And similarly, the aortic valve abnormality will be there, but the criteria which is fitting for rheumatic heart disease will not be there. Okay. So this is about the echocardiographic criteria for diagnosing rheumatic heart disease in individual less than 20 years who is asymptomatic. Definite rheumatic heart disease, borderline rheumatic heart disease with normal echocardiography. But for all those, you should be very much aware of when to call pathological MR, when to call pathological AR, what will be the morphology of the mitral valve in case of rheumatic heart disease, morphology of the aortic valve in rheumatic heart disease. Okay, right. Now, after having discussed about the cardiac involvement, next is the joint involvement in rheumatic fever. So, in fact, the joint involvement is most common. It is seen in nearly around 60 to 75% of patients, right? And this joint involvement will be in the form of the arthritis. And the arthritis what you are observing will be the migratory arthritis. Okay, so in this particular joints which are affected, the joint, it will be hot, the joint, it will be swollen, it will be red or even tender. So this will be the description of the joint which is being affected. And the type of polyarthritis will be migratory polyarthritis. Now what do you mean by the word migratory polyarthritis? That means the signs of inflammation will be there from in one joint. That signs of inflammation which are present within one joint, that will be there for hours. That will be there for a period of hours. And this signs of inflammation in that particular joint will reduce, then they shift to the next joint. That is what is your migratory arthritis. And the joints which are commonly affected are large joints, that is knee, and then ankle, then followed by that involvement of hip and as well as the elbows. So these are the large joints which are being affected. But you have to remember that in case of rheumatoid arthritis, where there is small joint involvement, in rheumatoid arthritis, it is symmetrical involvement of the small joints. But whereas in rheumatic fever, the large joint involvement, whatever is there, it is asymmetrical involvement. Okay. And what will be the drug of choice for this joint involvement? Remember, it is aspirin, that is acetyl salicylic acid. And this aspirin should be given in high dose, right? So when the pain is very severe and usually disabling in character, then you need to give the anti-inflammatory medication, that is aspirin should be given. Okay, right. And this aspirin that you are giving, it should be given in the high dose, right? And in spite of giving aspirin, you have given aspirin for nearly around 1 to 2 days, but the joint pain did not subside, then your acute rheumatic fever is ruled out. Okay, after more than 1 to 2 days of supplementing aspirin, the joint pain, if it does not subside, then it is not the arthritis of the acute rheumatic fever. Okay, please remember, this is very, very important point. Next, then followed by that, right, followed by that, if there is less severe joint involvement, do we consider it as the rheumatoid arthritis? Yes. Less severe joint involvement is also relatively common and has been recognized as major manifestation according to the Jones in high risk population. What is high risk population and all? I will discuss. So less severe joint involvement can be taken as one of the major criteria according to the Jones in the high risk populations. And in this high risk populations, you need not have all the signs of inflammation. Only if arthralgia is there, that means if there is presence of only the pain, that is enough, right? If there is presence of only the pain, that is enough as the major criteria in the high risk population. Okay, right. So all the signs of inflammation need not be there. So this is about the joint involvement. Then CNS manifestations. And this Sydenham's chorea, it develops after a very long latent period of nearly around 6 months. Okay. So there will be a prolonged latent period of nearly around 6 months. And this Sydenham's chorea, which is characterized by involuntary movements, this is very commonly seen in females rather than males. And you will notice the coriform movements. And these coriform movements, they are particularly observed in the upper limb, that is within the hands. And not only that, you have the characteristic coriform movements even within the tongue. Right, even you have the characteristic coriform movements even within the tongue, that we call it as darting movement of the tongue. Then followed by that, you have these coriform movements even within the upper limb. And in certain group of individuals, this coriform movements, they are restricted to one side of the body. When they are restricted to one side of the body, that we call it as the hemichorea. That we call it as the hemichorea. And you take mild cases of Sydenham's chorea. In mild cases, you don't observe that vigorous coriform movements of the upper limbs or the hands. So in order to examine that particular coriform movements, you need to do careful examination. Right? You need to do the careful examination of the extremities. Right? Then, whereas in severe cases, careful examination is not required, right? In severe cases, the affected individuals, they are unable to perform right, they are unable to perform the daily activities. Okay, so that is in case of severe cases. And these patients with Sydenham's chorea, they are also associated with the emotional lability, or there can be development of obsessive compulsive traits or obsessive compulsive disease, right? And this particular coriform movements or the obsessive compulsive trait, this will last for very long duration. Okay, so this may resolve within 6 weeks of time, but sometimes these coriform movements, this emotional lability can be there even for up to 6 months. And most of these patients, almost 50% of patients with Sydenham's chorea, they are associated with carditis. So that is the reason why all these patients with Sydenham's chorea, they have to undergo workup for the carditis. Okay. Then, how do you treat this Sydenham's chorea? If it is a mild case, first of all, what you have to remember is medications, whatever you are giving for the treatment of Sydenham's chorea, they do not alter the outcome of the chorea, right? They do not alter the outcome of the chorea. And in mild cases, you don't require to give any particular drug. You need to just provide the calm environment, right? You need to provide the calm environment. Whereas in moderate cases, previously we were giving this carbamazepine or sodium valproate. These are the one which are more preferred, right? Carbamazepine and as well as sodium valproate, they are the one which are more preferred than compared to that of the haloperidol. Whereas in severe cases, we need to give steroids. Okay, and this particular steroids, which steroid you have to give? Whenever you are giving this steroid, it has been found that there was rapid reduction of the coriform movements, and it is mainly given in case of the severe cases. And the steroids what you are giving is, you have to give prednisolone or prednisone. Same, this prednisolone, whatever you are giving, you have to give it a dosage of 0.5 milligrams per kg per day, right? And after that, you have to give for a week and then wean off, right? You have to give for a week, and then after 1 week, if the symptoms are getting reduced, then you wean off this particular prednisolone. Okay, then in refractory cases, those individuals not responding to your steroids, in them what the studies have shown is supplementing intravenous immunoglobulin, it has been shown to lead to more rapid resolution of the chorea. Okay, so that is in case of refractory cases. So this is about the treatment of Sydenham's chorea. Mild cases, just provide the calm environment. In case of moderate cases, you have to give carbamazepine and as well as the sodium valproate. In severe cases, you need to give prednisolone. In refractory cases, you need to give intravenous immunoglobulin. Okay, then coming to the skin manifestations. The skin manifestations are in the form of the erythema marginatum. Now, what this erythema marginatum, this is the classic rash that you come across in patients with the rheumatic fever. It's a classic rash of the acute rheumatic fever. Which one? The erythema marginatum. And what will be the color of the rash? It is pink macule. And this pink macule, it is having a clear center, right? Centrally it is clear, right? And totally surrounding it is pink in color. In morphology, if you see, it is serpiginous, spreading edges. And if you see this particular rash, it is evanescent. Right? It is evanescent. That means it appears and disappears before the examiner's eyes itself. That is what is called evanescent. It appears and disappears. And if you see the distribution of this particular rash, it is distributed over the trunk, and sometimes it is distributed over the limbs, but never on the face. Right? Never on the face. Okay, so that is about the skin manifestations. Then another important manifestation is the development of subcutaneous nodules. These subcutaneous nodules, if you observe, they are painless. And if you take the morphology of these subcutaneous nodules, they are very small. And what will be the size of this subcutaneous nodule? It is around 0.5 to 2 centimeters. And where these particular subcutaneous nodules are distributed, they are distributed beneath the skin, overlying the bony prominences. Right? They are being distributed beneath the skin, overlying the bony eminences. Right? Particularly, they are distributed over the hands, they are distributed over the feet, they are distributed over the elbows. Right? They are distributed over the occiput. Okay, so this, and even the vertebra. These are the areas where the subcutaneous nodules are being distributed, and this is also one of the delayed manifestation. And this subcutaneous nodules, it appears, right, it appears 2 to 3 weeks after the onset of the disease. Right? 2 to 3 weeks after the onset of the disease. So it is one of the delayed manifestation. And whenever it appears after 2 to 3 weeks after the onset of the disease, it remains for few days. Right? It remains for few days up to 3 weeks. Right? It remains for few days up to 3 weeks. And this subcutaneous nodules, similar to that of your Sydenham scoria, it is also associated with carditis. Right? It is also associated with carditis. So this is about your subcutaneous nodules. Then, so these are the major manifestations whatever we have discussed. That is arthritis, carditis, Sydenham scoria, erythema marginatum, and then subcutaneous nodules. These are the major manifestations. Now, the other manifestations what I'll be discussing is the minor manifestations according to the Jones. That is the first, fever. Fever, it is seen in most of the cases of the rheumatic heart disease, right? And this particular fever, whatever you see, it is a high grade fever. The temperature will be more than or equal to 39 degrees centigrade. So the presence of high grade fever is the rule. And these patients, they also have elevated acute phase reactants. What will be that elevated acute phase reactants? That is, there will be elevated ESR and as well as the C-reactive protein. And there should be evidence of preceding group A beta hemolytic streptococcal infection. Now, and that particular evidence, it is mainly the serological evidence. Now, what is this particular serological evidence? That is, the ASO titer is being elevated and anti-DNase B titer, right? Anti-DNase B titer, even that is also being elevated. So, this will be your serology. ASO titer and as well as anti-DNase B titer is being elevated, and that is the evidence of preceding group A beta hemolytic streptococcal infection. Now, coming to the confirmation of the diagnosis. Remember, there is no definite test to diagnose the acute rheumatic fever or rheumatic heart disease. Diagnosis of acute rheumatic fever it completely relies on the presence of the typical clinical features. Along with the typical clinical features, there will be also the individual having preceding group A beta hemolytic streptococcal infection, and that can be diagnosed by your serology. Now, based on the clinical features and as well as serology, Dr. Jones, right? Dr. Jones has made a criteria which is called Jones criteria for the rheumatic fever. In that, you need to know what is the, right? In that, you need to know what is the diagnostic criteria for initial acute rheumatic fever, and you should know what is the diagnostic criteria for the recurrent acute rheumatic fever. So this is the right new criteria which we call it as modified Jones criteria. Now, first of all, in this modified Jones criteria, you need to be aware of the two important populations. One is low risk population and the other one is the high risk population. To call it as low risk population, right? To call it as the low risk population are those with acute rheumatic fever incidents less than or equal to 2 per 1 lakh school aged children, or all age rheumatic heart disease prevalence of less than or equal to 1 per 1000 population per year. This is what is your low risk, right? If it is like school aged children, the number of cases should be less than 2 or equal to 2 per 1 lakh population. Of you take any age, if the incidence in that particular area is less than or equal to 1 per 1000 population per year, that is also the low risk. And anything more than this, right? Anything more than this we call it as the high risk, right? This we call it as the high risk population. Now, because why did we divide that into low risk and high risk is certain manifestations of major and certain manifestations of minor are different in low risk and as well as the high risk populations. Okay. So now, first of all, to call it as in the initial acute rheumatic fever, that is first episode, what is the diagnostic criteria? There should be two major manifestations, or there should be one major plus two minor manifestations. That is for initial acute rheumatic fever. But for recurrent cases of acute rheumatic fever, there should be two major or one major plus two minor or three minor manifestations. Okay, this is for recurrent acute rheumatic fever. This is for recurrent acute rheumatic fever, right? This is a diagnostic, these are the number of the criteria which are required for the diagnosis of acute rheumatic fever in the initial, that is first episode, and as well as recurrent. Now, in this Jones criteria, modified Jones criteria, like we have the major criteria and minor criteria, but this major and minor criteria are slightly different in the low risk population and as well as the high risk population. So, first is the carditis. Carditis, that definitely will be there in both low risk and as well as moderate and high risk. Whereas, if you take the arthritis, it is slightly different. If you take in low risk, the arthritis, it should be polyarthritis only. Whereas, arthritis in case of moderate to high risk, it should be either monoarthritis, if single joint all the signs of inflammation is there, or if there is polyarthralgia, then also we take it as the major for moderate to high risk population. Even there can be polyarthritis as well. What I mean to say is, even monoarthritis is there, we will take it as major criteria. Even if polyarthralgia is there, we will take it as major criteria. Polyarthralgia means you will have only pain. Other signs of inflammation will not be there. Then the next is, the other three will be same for both. Presence of chorea, it is same for both. Presence of erythema marginatum, it will be same for both. Presence of subcutaneous nodules, this also will be the same for both. But the only difference comes where? That is for the arthritis point. Okay. Next. Now you take the minor criteria. For minor criteria also, like we have the difference in the low risk and as well as the moderate to high risk population. And here the difference comes at 2 points. Not one is joints, the other one is the acute phase reactants. For low risk population, it should be it should be polyarthralgia for low risk population. But for moderate to high risk population, it should be monoarthralgia, right? For low risk, it should be poly, whereas for moderate to high risk, even monoarthralgia is there. We can take it as minor criteria. Presence of fever, right? That should be more than or equal to 38.5 degrees centigrade. That will be same for both, right? That will be same for both. And for the, for moderate to high risk, even 38 degrees centigrade is also taken as minor criteria. But the point of difference is for ESR and as well as the CRP. For low risk, the ESR, it should be more than or equal to 60 mm in first hour. Whereas for moderate to high risk, the ESR should be more than or equal to 30 mm in first hour. Okay, that is about the ESR. And what about the CRP, that is C-reactive protein? C-reactive protein, it should be more than or equal to 3 milligrams per deciliter in low risk, and as well as even it should be same more than or equal to 3 milligrams per deciliter even for moderate to high risk population as well. And the other point is there should be prolonged PR interval. Right? Even for moderate to high risk, there should be prolonged PR interval. Okay. So this is for the minor criteria. Now, all these minor and major criteria, right? So this is for initial acute rheumatic fever, there should be 2 major or 1 major plus 2 minor. For recurrent acute rheumatic fever, 2 major or 1 major plus 2 minor or 3 minor manifestations. That is for recurrent acute rheumatic fever. Now, after having discussed about the modified Jones criteria, now let us discuss the treatment for the rheumatic fever. What you have to understand is that patients with the acute rheumatic fever, mainly for patients with possible acute rheumatic fever, they should be followed closely to ensure that the diagnosis is confirmed, right? And you have to ensure that the follow-up is very much required for the treatment of the heart failure, if at all, if the individual develops heart failure secondary to valve involvement. Okay, and all other symptoms have to be undertaken. And all these patients with possible rheumatic fever, how is that you will follow up? You have to follow up by echocardiography. Echocardiography should be performed in all possible cases of the rheumatic fever. Okay, and you have to look for the valve involvement and if there is any development of the carditis, right? And as such, there is no specific therapy for rheumatic heart disease. It is only symptomatic treatment for acute rheumatic fever. So first and foremost, very important is the antibiotics, because your rheumatic heart disease or acute rheumatic fever, it's a recurrent inflammatory disorder. Because it's recurrent, you need to give antibiotics. Now, which antibiotic is the drug of choice? Penicillin is the drug of choice, out of which your phenoxymethylpenicillin and as well as amoxicillin, they are the oral formulations, whereas benzathine penicillin, it should be given deep intramuscular. And whenever you are giving this phenoxymethylpenicillin, the dosage is around 500 milligrams. But if the weight of the child, right, if he is around less than or equal to 27 kgs, in that individual, you have to give 250 milligrams. You have to give 250 milligrams twice daily. Okay. Whereas you take amoxicillin, the dosage is 50 milligrams per kg. Maximum how much you give is around 1 gram daily, and this has to be given for nearly around 10 days. Right, that is phenoxymethyl penicillin or amoxicillin should be given for 10 days. But if at all, if the injection has to be supplemented, it should be the single dose of the injection. And this particular single dose, it will be around 1.2 million units if the weight of the individual is more than or equal to 27 kgs, and if the weight of the individual is less than or equal to 27 kgs, then you have to give 6 lakhs units or 0.6 million units should be given. That is about the dosage of the benzathine penicillin, right? And remember, you should never give IV. If you give IV, there can be anaphylactic shock and death of the individual. And those individuals who are allergic to penicillin, in them you need to give erythromycin should be supplemented, okay? Now, for the joint pains. Joint pains already we have discussed. The drug of choice is aspirin, that is salicylates. So this salicylates, if arthritis is there, we give salicylates. Even arthralgia is there, we give salicylates. Even for fever also, you can give this particular, the aspirin, right? Now, this particular salicylates, remember, there is no proven value for carditis. If there is development of carditis, aspirin, you don't have much of the value. Even for chorea, the aspirin has no much value. If it is only for arthritis, we are giving this salicylates. And the dosage of the, so drug of choice will be aspirin. The dosage is around 50 to 60 milligrams per kg, right? 50 to 60 milligrams per kg per day, right? And maximum how much you have to give? Maximum you can give up to 80 to 100 milligrams per kg per day, right? That is the maximum dose. And this dose, whatever you are giving, you should give it in 4 to 5 divided doses, not at once. Right? 4 to 5 divided doses. Now, if you see the toxicity of your salicylates or the aspirin, regarding the toxicity, you have to monitor it very closely, because these patients, they can develop nausea, vomiting, and there can be also development of, right, there can be also development of tinnitus if the symptoms appear. Okay, so these are the things that you have to look for, the toxicity of the aspirin. Okay, and if these symptoms appear, what you have to do is, instead of using the high dose, you have to use the low dose of aspirin. Okay, now if suppose you have given aspirin and there is early resolution of the symptoms, if there is early resolution of the symptoms within first 2 weeks, then instead of the high dose, the dose has to be reduced to, so high dose means what? 80 to 100 milligrams per kg body weight. So the dose has to be reduced to 50 to 60 milligrams per kg body weight per day if there is early resolution of the symptoms, right? And this has to be continued for nearly around 2 to 4 weeks. But the point what you have to remember is, once you stop aspirin, right? Once you stop aspirin, fever and as well as the joint manifestations and elevated ESR, that may appear back. There can be recurrence, right? So these symptoms, they recur up to 3 weeks after the medication is being discontinued. So after 3 weeks of stopping your aspirin, there is a chance of recurrence of these symptoms. So then what you have to do? You have to give the aspirin again for a brief period of time. Okay, so that is about your story of aspirin. But some children, they cannot tolerate aspirin. There is chance of development of a syndrome called Ray's syndrome. So in those individuals who are at increased risk of development of Ray's syndrome or toxicities of aspirin, in them you need to give this naproxen. So this naproxen, it is like safe, okay, and it is safer than aspirin, right? It is safer than aspirin, and the dose what you give is 10 to 20 milligrams per kg per day. The advantage of this naproxen over the aspirin is that this has to be administered only twice daily. Whatever this 10 to 20 milligrams per kg per day is there, this has to be given in 2 divided doses. But whereas aspirin, that 50 to 60 milligrams per kg per day, it has to be given in 4 to 5 divided doses. That is the advantage of naproxen over the aspirin. Now, if the individual develops the congestive heart failure, now this role of your glucocorticoids, it remains controversial. Some studies have shown definitely there is role of glucocorticoids in those individuals who have developed severe carditis. So those patients who have developed severe carditis, it is preferred to give the steroids so that this particular severe carditis, it will not progress to the development of the congestive heart failure. What these steroids will do? These steroids, they will reduce the inflammation of the carditis. And by reducing the inflammation of the carditis, they will cause rapid resolution of the failure. That is the advantage of giving steroids in case of severe forms of the carditis. And whenever you are giving, you need to give the prednisolone or prednisone. And the recommended dose for the development of severe carditis is 1 to 2 milligrams per kg per day. But maximum how much you can give, whatever might be the weight of the individual, is you need to give 80 milligrams per day. Okay, usually for few days, or maximum you have to give it for up to 3 weeks, right? That is max. And after that, you need to taper and stop the steroids. Okay, but after the development of congestive heart failure, the role of steroids, it is controversial. Only when the individual is in a state of like carditis before the development of congestive heart failure, you can give this glucocorticoids. Okay, next, coming to the requirement of bed rest. Okay, so requirement of long-term bed rest, right? It is no longer widely practiced. Okay, long-term bed rest is not required. When is the bed rest required? If the individual has developed severe arthritis, if the individual has developed the features of congestive heart failure, in them the bed rest is being required. Okay, and once the symptoms are controlled, then you should advise the gradual mobilization of the individual, right? Gradual mobilization of the individual. And how will be the prognosis in these individuals with rheumatic fever? Untreated cases of acute rheumatic fever, right? Your aspirin is not being given, glucocorticoids not given, benzathine penicillin not given. So untreated acute rheumatic fever, on an average, right? On an average, it lasts for 12 weeks. Right? It lasts for 12 weeks. Okay. Whereas with the treatment, you can discharge the patient from the hospital within 1 to 2 weeks. Right? With the treatment, you can discharge the patient from the hospital within 1 to 2 weeks. And what you have to monitor? You have to monitor the inflammatory markers that should be monitored every 1 to 2 weeks. Right? The inflammatory markers have to be monitored every 1 to 2 weeks until they get normalized. Right? Until they get normalized. For how many weeks it takes for normalization of the inflammatory markers? It takes nearly around 4 to 6 weeks for the inflammatory markers, that is ESR and CRP, to return back to normal. And the next thing is you have to repeat the echocardiogram after 1 month. That is mainly to look for the valvular abnormality and to look for is there any progression of the carditis. So this is how you have to monitor. That is based on the inflammatory markers and as well as the echocardiography. And if you take the primary prevention here, primary prevention is to prevent the infection with group A beta hemolytic streptococcal infection. So one methodology of prevention is overcrowding should be minimized. Right? Overcrowding should be minimized because this particular sore throat or skin infection, they are being contagious. They can spread easily to the others if there is overcrowding. But this is little difficult to achieve in most places where acute rheumatic fever is common, because most of the times this acute rheumatic fever is very commonly seen in individuals with low socioeconomic status. It is not always, but mostly. And individuals with low socio-economic status, right, there will be overcrowding within the house, so where there can be the spread of this sore throat, okay, or there can be spread of this impetigo. And what is the mainstay of treatment for primary prevention? The mainstay of treatment for primary prevention going into a state of the rheumatic fever is that once the individual develops sore throat, then you have to supplement the entire treatment which is given for the treatment of group A beta hemolytic streptococcus. So you have to give complete course of the antibiotics in those individuals who have developed sore throat, right? So that can prevent the progression to the development of the acute rheumatic fever, okay? And if at all, if you are starting this full course of antibiotics, this full course of antibiotics, they should be started within 9 days of onset of the development of sore throat, right? And what is that antibiotic that you need to give? That is beta-lactam group of antibiotic, that is penicillin should be given, right? Penicillin should be given. So what you have to remember is that when you are giving this full course of antibiotic in all the individuals who has developed the sore throat, there is a chance of over treating many cases of sore throat, because this particular sore throat which has been developed may not be because of your group A beta hemolytic streptococcus, but there is chance of over treating when you are treating all the cases of your sore throat with complete course of antibiotics. But treating this sore throat with full course of antibiotic, that is the mainstay of the primary prevention. Then what is your secondary prevention? Secondary prevention is controlling acute rheumatic fever and controlling rheumatic heart disease, right? Controlling acute rheumatic fever and rheumatic heart disease, that will be the secondary prevention. And see, what are the drugs that we are given for secondary prevention? It is, you are preventing the recurrence. And how can you prevent the recurrence? It is same by your penicillin. And this prophylaxis, it is very much preferred in the high risk population. And I have also already discussed what do you mean by the word high risk. Now, the prophylaxis, whatever you are giving, it should be given every 4 weeks. Okay. What is that your prophylaxis you are giving? That is injection benzathine penicillin. The dosage is same, whatever we have discussed. That is 1.2 million units in individuals of age group of weight more than or equal to 27 kgs. If less than 27 kgs, then you need to give 6 lakhs units. Okay. Then those individuals who are allergic to penicillin, what you will give? That is, you need to give erythromycin. And this erythromycin, 250 milligrams, erythromycin is what you need to give. But whenever you are giving erythromycin, it has to be supplemented twice daily. Or, okay, and those individuals who don't want the injections in them, you can give oral penicillin V, which is of a dosage of 250 milligrams. This has to be given twice daily. But this oral penicillin V, it is slightly less effective than compared to that of the benzathine penicillin. Okay. Now, this prophylaxis should be given every 4 weeks. But in those individuals who are at high risk, depending upon the severity of the symptoms, the prophylaxis should be given every 2 weeks or every 3 weeks. The prophylaxis should be given every 2 weeks or every 3 weeks. But low risk individual, give the prophylaxis every 4 weeks. Okay. Now, like what should be the duration of the prophylaxis? It completely depends upon what is the underlying valvular abnormality or what is the underlying cardiac pathology the individual is having. If the individual is having rheumatic fever without carditis, you have to give for 5 years, right? You have to give for 5 years after the last attack, right? After the last attack, or you have to give up to 21 years of age, whichever is longer. Right, up to 21 years of age, whichever is longer. Okay, like for suppose, just an example, if the individual has developed rheumatic fever or rheumatic heart disease or rheumatic fever, let us just assume, because the first one is without carditis, right? So if the individual has developed rheumatic fever at the age of 19 years, then after 19 years you have to give for the prophylaxis for 5 years, right? For suppose, if the individual has developed rheumatic heart disease or rheumatic fever at the age of 13 years, then you have to give it for 21 years. Okay, up to 21 years, right? Because that is longer. And if there is rheumatic fever with carditis but no residual valvular heart disease, in this case, you have to give for 10 years after the last attack, or you have to give it up to 21 years of age, whichever is longer. This is in case where there is no valvular heart disease. Whereas in individuals with rheumatic heart disease with persistent valvular heart disease, in such case, you have to give for 10 years after the last attack, or you have to give up to 40 years of age, whichever is longer. So this is about the duration of the prophylaxis. Okay, so to finally conclude about the rheumatic fever, remember, it is not a direct infectious pathology. It's a recurrent inflammatory immune mediated disorder, and the basic pathophysiology is molecular mimicry, and the most common manifestation will be polyarthritis, then carditis, erythema marginatum, subcutaneous nodules. Last manifestation will be the chorea. Minor manifestations will be fever, then prolonged PR interval, raised ESR, and as well as CRP. And you need to know what is low risk and high risk population. And individuals who are asymptomatic, age group less than 20 years, you need to know what is definite rheumatic heart disease, possible rheumatic heart disease based on echocardiographic criteria. Then lastly, you need to know that drug of choice for arthritis will be salicylates, and you need to know how to treat the chorea depending upon the severity. Mild cases, just calm environment. Moderate cases, carbamazepine or sodium valproate, right? And in severe cases, steroids. Refractory cases, intravenous immunoglobulin. And you need to know like what should be the duration of the prophylaxis. So this completes the discussion of your acute rheumatic fever. Thank you very much.